Why don't you go, Jeff? Show us your case, and I'll show mine.
All right, I'll go. All right, here. Let's start with this one. So this is an 89-year-old, and I'll pull up her images in a second, who was transferred to us, chest pain, and aortic pathology. But I wanted to show this case because I think it's the, put them up side by side. There we go. There. Do you see both acquisitions? Does it show the
one so far?
Oh, that's right. It only shows one. Let's see if I can figure it out. I don't know how to make it show both side by side, which is very unfortunate. Well, do you see the non-con or the contrast?
Non-con.
Okay, well, let's start with that. So here we can see the displaced intimal calcifications, and there's clearly intramural hematoma. It's not particularly high attenuation, maybe a little bit. Some of that's artifact, but maybe up here you see it's a little bit denser. So we have an intramural hematoma, and it's involving the descending aorta. What's more interesting is the contrast study. So I can switch it over. Now you should see the contrasted studies. You can see she happened to have pulmonary emboli just for fun. But what I liked about this case, and we can get into a discussion about it, is we sometimes see sort of slow flow in these channels, but in this particular case, we have much denser contrast, and you can see it running deep to the plaque. So it's clearly in the wall of the aorta, and so it has different little pockets here. So I suspect this was probably an atherosclerotic ulcer that ruptured into the media. But I really like this image down here where you can see contrast outside the intimal calcification. So a lot of the intramural hematomas I've seen have much slower flow, and you don't have this dense of contrast or mixed blood and contrast in there. But you see these little pockets, and it just goes all the way down. And then it kind of stopped at the diaphragm, but just a really ratty aorta. They ended up stenting this, and patients doing okay. But
Jeff, can you take us back to the aortic arch? Was there any filling of the cuff around the calcification in the arch?
Right up here.
Huh.
Not much. But my theory is it probably ruptured right in here.
Yeah.
Where this plaque is, or sort of plaque, and it just kind of tracks along in there. But yeah. And then why she threw pulmonary emboli at the same time, I have no clue. I can't explain that.
Oh, that is interesting.
Yeah, I've just not seen one. So I guess we've seen dissection flaps, we've seen intramural hematomas, but I've not seen one with this extensive atherosclerosis where probably this falls in that penetrating atherosclerotic ulcer spectrum, where that's probably where the entry is, and then and whether there's more entry or sort of if it's fenestrated or what, I don't really know.
Can you follow down to can we look down in the abdomen too? Let's just track this thing down.
Yeah, it's kind of peters out once you get towards the abdomen. See there, the wall looks pretty good. It's all that's just all atherosclerosis.
So I would actually disagree, Jeff. I think that this is probably a type B dissection that arose distally from the arch.
Mm-hmm.
And that really have the elongation of this abnormality, the fact that you've got a second channel that goes for centimeter after centimeter like this, for a foot here, is really an indication that this is a very extensive lesion, and that argues against penetrating ulcer, which tends to stay localized.
Okay.
So I think this is really a type B or maybe even a type A dissection. I don't quite know where it started. But I think the elongation of this thing is really a strong argument for dissection and against penetrating ulcer.
And we're just not seeing a flap.
You have this intermittent filling. And you're correct to point out that there's a lot of atherosclerosis here. That's usually protective against dissection, and it may be operating in this person. When you get a lot of atherosclerosis, you actually weld the layers of the aortic wall together, and you make it difficult to get a clean dissection plane and have it, fill out two channels very nicely. But the fact that her contrast filling of the second channel is so sporadic here suggests that we may actually have that welding phenomenon going on here. We have just a few places where you can actually form the second channel.
I see.
But the elongation here, I think, really supports dissection.
Okay. Yeah, I've always, it gets, every time I read about it and discuss it, I thought I understand, and then maybe I get more confused because I think about sort of acute aortic syndrome, including dissection, penetrating ulcer, and intramural hematoma. I mean, they're managed the same way, but I guess the debate is where does it start? So you think this one actually started as a true dissection?
Yes.
Okay.
But I think the important thing here is the length of the abnormality here.
Okay.
The length goes with dissection.
Okay.
And against ulcer.
That makes sense.
Okay.
I like the well
Sometimes
theory though.
lesion, yeah, it's not rare to have an acute aortic syndrome when you have features of more than one simultaneously. So sometimes these might be hard to separate according to the classic distinctions we try to make. This one's really interesting in that respect, yeah.
Well, I think actually, plain Jeff, it's quite interesting. You really have a pretty long continuous channel there.
Yeah.
Immediately.
She got stented.
Yeah, she got stented. Yes, yeah. They just put a covered stent across this, and
so they treated it as a type B dissection.
So cool.
So the other, I guess the other point to make here is that intramural hematoma is not a phenomenon. It is it's an epiphenomenon. So how do you get the blood in the aortic wall? So the blood can get in the aortic wall from dissection or from a penetrating ulcer or rupturing aneurysm, things like that. But it's not a separate entity. It's caused by something else, and what it's usually caused by is either penetrating ulcer, rupturing aneurysm, or dissection.
Some people think the vasa vasorum of the media actually is dystrophic and it ruptures in two. So
right, that theory has been around for at least 30 years and longer. And so the question about the origin of aortic dissection revolved around that for a long time. Was it an intimal tear or was it rupture of the vasovasorum that started aortic dissection?
Yeah.
So it's possible that that's another entity that would cause an intramural hematoma that we should add.
It's also the case that in recent years with multi-detector row CT and the increased resolution, spatial and contrast, shows it's not uncommon to have communication of opacified blood from the lumen to the wall of the aorta. And I think there's accumulating evidence that the so-called primary vasa vasorum theory is probably not operable.
Okay, well, here's another vascular case. This was another, this is an older man. I forget how old he is. I want to say in his 80s, who was transferred, it was a trauma, it was a motor vehicle crash, and had this interesting radiograph. You can see there's obviously not really an apical cap, maybe an apical, what do they call those giant bear skin things that the Napoleon soldiers used to wear? A very large extrapulmonary extrapleural hematoma, but also has right paratracheal stripe thickening. He's had some previous heart surgery. It looks like a cabbage there with a little clip and some Lima clips. And what's odd about him, and let me pull up this is his initial CT, is you can see he had a hemothorax on the right, and you don't see it. There we go. You have a hemothorax on the right, a hemothorax on the left, and there's mediastinal blood and a little stranding anteriorly, but this huge extrapleural hematoma that seems to be arising probably from a subclavian or subclavian branch. There's this extravasation in this area. But what's odd is he's got all this gas in the mediastinum. So when I got a little bit more information, I found out he'd actually ruptured his esophagus. How, I can't figure out. Esophageal rupture from blunt trauma is actually very, very uncommon. It's usually from penetrating trauma. What's interesting, though, is so this hematoma has subsequently progressed. So that the radiograph I showed you was when he first came in. Here is the subsequent one. You can see it's gotten a lot bigger at this point. He's now intubated. This huge extrapleural hematoma. Someone decided to put a drain in it. I'm not sure why. And you can see the mediastinum is relatively stable at this point. So they CT'd him the next day, and it's kind of interesting. So at this time, nobody's done anything with his esophagus. No one has operated on it. They didn't want to touch him. Someone managed to get a gastric tube down, and you can see. Let me make sure we're seeing it here. I should see this. What's kind of cool is you see the extrapleural hematoma, and then you see extrapleural fat, a little bit of pleural fluid, and then the collapsed lung. So you can see, really distinguish this from a hemothorax. In this case, you get that fat stripe sign. As far as that upper lobe, that's subclavian thing, we didn't really see the extravasation at this point. There was just the small branch vessels. So we kind of surmise that he's auto-tamponading, and maybe that's what's going on with this mediastinum as well, that he managed to tamponade some of the, contain his rupture with a bunch of blood. Now, it must have been a small tear or something, because I would expect to see more gas even without this tamponade effect. But I thought this was just a really impressive extrapleural hematoma, probably coming from his subclavian. And I think that was the final radiograph on him. So this is probably one of the bigger ones I've seen, but it was sort of like a parfait here. You got blood, fat, pleural fluid, collapsed lung.
Perfect.
All right. And then this last one is probably the most interesting case. I don't know much about the story, but this was presented at our pulmonary conference. But this is a young man who presented with this mass-like area of consolidation on a chest radiograph, was treated with antibiotics for infectious pneumonia, did not get better, had radiographs done about, let's see, that was about 2.5 weeks later, and the area of consolidation got larger. They did a CT scan. Actually, at the time, this is going back to the initial presentation, but has this area of consolidation, right upper lobe, looks like a right upper lobe infection, expiratory scan. Wouldn't thought much else about it. He didn't get better on subsequent imaging, so they ended up doing a PET CT at this outside facility. And I'll see if I can bring up the PET. So these are the FDG images that you should be seeing. And what you'll see is, here we are at the in the chest, and you see there's this ton of uptake in the chest, in that right upper lobe. And then as we go down into the abdomen, here's liver, that we see a lot of uptake in the retroperitoneum, in the paraspinal space. Now I will bring up, and I think I can get Osiris to fuse these for you and then show you the correct screen. So you now should see a fused PET. I think Osiris is mapping it.
Yes.
Good. So we see there was a nodule in the left lower lobe. He had some uptake, but this area of consolidation continued to enlarge. And what was not known about at the time was this area here, and I'll take off the fusion now. Let's see if it'll do that. And you can see, blow this up, there is this soft tissue surrounding the aorta, and you can see the aorta and the iliac arteries because of the calcification in them. And then sort of everything kind of being pulled into this mass here. So this is retroperitoneal fibrosis. So anyone know what this is? So they did a biopsy of the lung, and this all is IgG4 related disease.
Yep.
And he was given, let's see if I have a follow-up. I forgot to get the last one, but he was treated with corticosteroids, and this stuff started to melt away. So
that's impressive. Going back to the abdomen, is there any pathology related to liver or pancreas, just out of interest?
It was a non-contrast. I'm not aware. No, that's one thing we did, that my colleague who showed me about this case, told me about this case, did mention there was really nothing around the pancreas. It's pretty normal. And the liver was normal in the non-contrast study. And I don't remember anything on the PET.
So, Jeff, what is in the lung? Is that lymphoma, lymphoid tissue?
It's lymphocytes, yeah.
Lymphocytes.
And plasma cells dropping immunoglobulins. Why it causes a lobar consolidation, I don't have the answer to that.
There's a lot of pathology there, and sometimes the pathology of the lung in IgG4 related sclerosing disease is distinctive.
Mm-hmm.
If you have two things in particular, one is the phlebitis, and the other one is a form of fibrosis that the pathologists describe as a storiform fibrosis,
mm-hmm.
as well as the lymphocytes. So sometimes they see a complex of pathological findings that, if they're thinking about it, is very suggestive of that entity.
Okay. Yeah, it's very odd. It's a very odd phenomenon. But yeah, this was quite impressive, and I didn't get to see the pathology, but I heard it was quite the pathologist, the pulmonary pathologist describing it was excited about it and showing the IgG4 staining and all that stuff. All right. Well, those are my
Yeah,
cases this week. I see Brent's
yeah,
on.
those are great. If you can get the pathology, that'll be really neat. If you can get even the description of it, I'd love to read it.
Yeah, I'll see if I can dig up the path report.
Okay. All right, let's take a look at this one first. So I will tell you that when this person came in, she was diagnosed with PE. And let me just scroll through it without any comment. So switch over to the lungs just to show you what's in the lungs. And then go back to the pulmonary arteries. And I think that I'm sure those of you that have seen this before will know immediately that this is an ordinary PE. Then I will show you the follow-up when the patient was anticoagulated, came back with symptoms as you might expect. And you will not be surprised to see that things are not better. So here we go. So a biopsy, a needle biopsy was done of this lesion down here. And I know that wasn't an appropriate one to go for because that has features of an infarct, whereas these round things do not look like infarcts. So findings very typical, all in all, of a pulmonary artery sarcoma. So we have a very large tumor here. You can see the scalloping of the mucosa. On the previous one, which was obtained with a slightly different timing, I'll show you that one can perceive that the tumor is enhancing. So particularly at this level up here, approximately here particularly, you can see that there is irregular enhancement of the mass in the main pulmonary artery. So initially diagnosed as PE, but this is pulmonary artery sarcoma. The patient died, and there is the diagnosis there. Here are some images from the autopsy showing you the tumor in the vessels. Very extensive tumor. So the complex of findings are very typical of that. It's really an unfortunate diagnosis. It's a terrible prognosis, but in a case of pulmonary artery sarcoma. All right, let me show you this one. This is an oncology patient. I'm just going to withhold some information for the moment, but this is a CT from last year. And then the CT in follow-up that was particularly interesting started to appear in October. And you can see here, I will show you what the lungs look like, this being October. And give you a feel for these bilateral diffuse centrilobular nodular pattern. I'll also show you that in October, let's have a look at these lymph nodes. They're a little bit big, and that's a new finding. So the hilar, the suprahilar, infrahilar, intrapulmonary lymph nodes are a little bit big. Now I'll go back further, to December, and you'll see that the lung disease is still present. It's a little bit more extensive. Here, in addition to being small nodules, there's almost some ground glass opacities admixed with the more discrete nodules, but clearly a progressive pulmonary parenchymal disease. And again, to show you the extent of the lymph node enlargement as well here in December. So the history is relevant here. The patient has a tumor that is thought to be arising from potentially the appendix. And she was treated with pembrolizumab. And we diagnosed pembrolizumab-associated drug toxicity. And they stopped the pembrolizumab. And the one that I'm not showing you is the follow-up, which I have, but I haven't anonymized it yet. But suffice it to say that all of that went away. Both the parenchymal disease as well as the nodal disease got better. So this is pembrolizumab-associated pneumonitis, we believe. Let me go back to the pathology, because I must say I wasn't expecting to see a report that really described a sarcoid reaction. But as you can see there, they are compact non-necrotizing granulomas, and it looks like sarcoidosis, at least under the microscope it does. But it really got better. So we're ascribing it to that drug in the absence of an alternative explanation. Has anyone seen perhaps a case of one of these PD-1 inhibitors like that?
I have not, Howard. It looks very, your images even look like sarcoid.
I know.
The upper lobe predominantly. I wonder if it...
Yeah. It's either a fake out and it's incidental, because the ones that we usually think of when we think of drug reactions are these patent cryptogenic organizing pneumonia, ground glass, or so-called interstitial, this kind of thing. This is from the article.
Yeah, interesting.
But sure looks like sarcoid, and it had granulomas. So if it is due to the drug, then it's a sarcoidal reaction. Like I think you can get with, I'm trying to remember the drug that's sometimes associated with sarcoid. I think it's either one of the interferons or one of the interleukins. Sometimes it's been associated with a sarcoidal reaction in the lung. Perhaps this is in the same kind of appearance, same kind of phenomenon, perhaps.
All you have to do is upset immunity and you get a sarcoid-like reaction. So I think the agent you're thinking about is part of the therapy for Hep C in the old days. I think they gave interferon, and that would sometimes trigger a sarcoid reaction. So it's not surprising you upset these T-cell programming and things like that, that you could, that could trigger it. So it definitely looks like sarcoid, and
yeah,
it makes sense.
Interesting. Yeah, and nodal disease. That's really interesting.
Mm-hmm.
So we've blamed her on this drug, and it's gotten better. That we do know. So perhaps it is a case of it, but just in the form of granulomas, which is interesting. All right. Do I have time still, Jeff, to show a few more?
Yeah. Go ahead.
Okay. This one is interesting from 2 points of view. One is the perceptual challenge. So let me bring this up. I've shown many cases like this before, but we're always humbled. So here's a chest radiograph in an outpatient, and I'll give you a moment to look at it just as you would see it on your workstation, something like that for the frontal projection of the chest. And then to bring up the lateral alongside, this is what the lateral would look like, and see how many things you see in terms of particularly lung lesions. So this one is easy enough to see, but I think even those of us that have been at this game for a long time will be somewhat surprised to see how many lesions there really are in the lungs. So you'll see down here there are lots of small nodules. There is motion and sharpness and some blurring from patient respiration, but here's a lesion there, and here's a lesion here, and here, and this particular one here is really hard to see on chest radiography. So that one you can only really see if you know where to look. And if you do something like this and something like that, and you see it down here. So this person has lots of nodules. And basically, I put this in my to follow up list, having described lots of nodules and waited for the biopsy, which of course eventually did happen. So here is the diagnosis under the microscope, consistent with metastatic renal cell cancer. I looked for additional adrenal imaging, but renal imaging, but I haven't seen any yet. And on this CT, we didn't really get all the way down. So presumably this is a metastatic renal cell cancer. We didn't really image much of the kidneys on that contract CT of the chest right there. But there could be a lesion right there. So who knows? But I was really impressed by how many lesions are hard to see. All right. This one is interesting. This is a nice kind of follow-up. So this starts off with a CTPA for pulmonary embolism. And let me bring up the thin cuts from that exam to show you. And no PE was present, but a colleague astutely made the observation of a little lesion. It's a good pickup. So I'll show that to you here, and I'll make it a bit bigger. Here in the apical left lung. And if you look at that carefully, you can see that it is likely a part solid nodule, but you can see it's small, little ground glass there, but maybe a solid portion anteriorly. Really hard to say. But we did recommend a follow-up of it, which did occur later. So let me go in time to April. So now we're going to have December and April. So let me bring up the follow-up here to show you. Rolling in the wrong direction, or what's going on here. There must be another sequence that I have to bring up. Let's try this one. Sorry about that. For some reason, I have something wrong. Oh, maybe it's here. Sorry about that. So this is the kind of case where you really have to look at the 1 millimeter cuts and make the comparison. And I did that, and I did it very carefully. And I will tell you, the only thing that I saw that was different was that this portion right there, that is the solid portion of this part solid lesion, is the only thing that had increased slightly from the comparison exam. But I looked at it, and I looked at it, and I measured it, and I decided it was real and described it as such. And indeed, it is a adenocarcinoma. You can see here the invasive component is small, so it's almost the so-called microinvasive adenocarcinoma. The pedic predominant is presumably the ground glass component of it, with no lymphovascular invasion or pleural involvement. So a nice example of the incidental discovery of an adenocarcinoma with growth of the solid component. Here is another one that's really similar, so let me bring both up. This is from the outside, so I don't have thin cuts really, but going in time here, they imaged this in January of 2016. I don't know what they were thinking at the time, and then we have the follow-up almost 1 year later. And this lesion I'm going to show you here is really very similar. It's a part solid nodule, and let's see what that does over time. If that increases a bit. I think that, and I didn't measure this one particularly carefully, but I wonder whether that solid component here had increased a little bit. But otherwise, a near identical lesion to the one that I showed you, a really typical part solid nodule. And this one too is a adenocarcinoma. This one also has no lymphovascular invasion and mixed lipidic and acidotypes. So nice teaching examples of so-called part solid lesions that both turn out to be an adenocarcinoma, invasive adenocarcinoma of lung.
Hey, Howard, on this current example you have up, it also nicely shows a little bit of a focal retraction of the fissure.
Let's have a look. Right there.
Yeah.
Okay.
I mean, in theory, you could get it with focal fibrosis, but I don't know. When I see that, and the other thing,
Yeah.
the other findings that have been described, this doesn't have it, is sometimes you'll see little notches in them, which have been associated with them being adenocarcinomas.
Notches in the
nodule, like little clefts in it, where it's like an indentation or something. Like right there, if you look on your solid component, right there, there's a little indentation at about 3 o'clock. Yeah, right there.
sort of this lobulated thing, yeah. But these are super nice teaching cases for the so-called pot solid nodule, exactly, and how they might evolve over time. Yep.
All right.
So they used to call that the tail sign of an adenocarcinoma in the old chest film days. You'd have a peripheral lesion, say, up in the right apex, and would often have a little line that went out to the pleura. So it was called a pleural tail, and that was supposed to help you distinguish a carcinoma from a granuloma. So it's probably the same phenomenon. There's probably a little fibrous tissue that's generated that actually is what causes the tethering here of the fissure, or the little line that would go out to the peripheral pleura.
Yeah. Yeah, I would predict if we had the histology here, we have a nice correlation between the lipidic portion surrounding it here somewhere, and then the invasive, in this case, acinar type portion, solid in here, with stromal invasion, but no lymphoid or lymphovascular invasion. Yeah.
You know, the scarring and the fibrous component of these adenocarcinomas, I used to think naively that was part of the body's attempt to isolate this lesion, to sort of form a crust around it and keep it from spreading. But it turns out the adenocarcinoma actually encourages fibroblasts to come in and lay down, you know, fibroblasts will put out these long appendages that will go through basement membranes, and then they will lay down fibrous tissue along that. So they are very good at penetrating basement membranes and invading tissue. So the adenocarcinomas then follow these little spicules that the fibroblasts have created. They actually grow along that, and they use that to invade. So you know, instead of being a defensive maneuver, it's actually an aggressive maneuver by the tumor to help it spread.
So it's like the zombie insects or whatever. It's using zombie fibroblasts.
That's right. So it's very zomboid.
All right, Jeff, those are the cases I have for this week.
All right. David, do you have any cases this week?
Howard, I could show the cases that I was planning to send to you. Are you interested in these cases of post surgical defects in the diaphragm?
Sure, yeah, great.
So can people see a coronal view?
Yep.
So this is a person who had a heart transplant that followed an LVAD. And at this point, you can see this is the transplanted heart, but here's the defect in the diaphragm. Here's diaphragm intact at this point. There's a hole in the diaphragm here where the LVAD was taken out. So in the old days, they put the LVADs in the upper abdomen. They brought them through the diaphragm into the left ventricular apex. This was a heart mate. And this person had splenectomy. This is actually, this little nodule here is a splenule that's left over spleen tissue. But you can see the continuity of vessels here across this diaphragmatic defect. So that's one post-LVAD diaphragm defect. Let's see if I can bring up the next case. I can't, so let's do it this way. Okay, so this fellow, let me get my list here. Okay, this fellow had a ablation of a hepatocellular carcinoma, radiofrequency ablation back in 2008, and has this defect at this point in the diaphragm that resulted from that. And at this point, we've got a little bit of fat going through it. And a later time, things get more interesting, and he starts to get more and more stuff going through the defect. This is a few years later, and you can see that there's a lot more fat penetrating now through this diaphragm defect. And then eventually, I think there was even some liver going up through that. So this is cross section, but do we have liver getting through it? Said to have liver. Let's see. Or this is actually, I'm sorry, this is after the repair, so I didn't include the lesion that showed increased herniation of stuff through this right hemidiaphragm. So does that case qualify?
Yes. Yeah.
Okay.
Yeah, very good.
I think there's one more here. Let me see. Okay, this is another, I think this is another LVAD problem. Okay, no. See, this fellow had, yes, did have an LVAD, had a heart transplant. He'd had several surgeries and it was extremely difficult to section. And they ended up repairing his anterior diaphragm after carving through a lot of scar tissue with this big piece of mesh here. So we got anterior diaphragm and then anterior chest wall. This is called an ESMARC, E-S-M-A-R-C-H procedure. Evidently was described using some membrane to enable them to close the abdomen without putting a lot of tension on sutures when there was a lot of swelling of the intra-abdominal contents. So this is a variation of that. I think that there you can see the graft material here in the anterior hemidiaphragm, and then it goes into the anterior abdominal wall here on both sides. So I think this was more of an abdominal closure issue and then reinforcement of the diaphragm in this case. I don't know, Howard, do you think this qualifies or is this too?
Probably not.
What?
Probably not.
Okay. Okay, so I'll send you the first two cases then.
Yep, thank you. Yeah, great.
So yeah, people at Augusta are going to try and show a cardiac MR. I'm going to stop the recording real quickly to make sure there's no PHI.
I will change it again to see if it changed. Can you see a new screen?
Yes.
Okay, this is a cardiac MRI from 6 months ago when patient came in for chest pain. His troponin was around 10, and they were worried about myocarditis. So patient got a cardiac MRI, and we did some T2-based sequences and maybe thought there was some edema in the myocardium. And then we did post-contrast delayed imaging, and it showed some mid-myocardiac enhancement. And we didn't see any pericardiac effusion, pleural effusion, any other secondary signs of myocarditis. So then patient comes back 6 months later with a similar presentation of chest pain, EKG changes, and patient went to a cardiac cath. And on cardiac cath, in the end, they thought the coronaries were all clean. The EF was a little bit low, and they thought the kid may have had Takotsubo cardiomyopathy. And then they did one more cardiac MRI this time, and this again they thought maybe he's got myocarditis. Again, was one of the other things they were wondering, and I was perplexed as to why a kid would be getting myocarditis twice in a year. So the wall motion wise, we did not find too many abnormalities in the wall motion as such. His EF had improved, and we did not see any apical ballooning to suggest Takotsubo cardiomyopathy. The other thing is the delayed enhancement, which we did again. So we did the T2 imaging. He could not hold breath so well. He got little Ativan for anxiety, and he had difficulty holding the breath. So he came back a day later to do the post-contrast imaging. And on the post-contrast imaging, the delayed enhancement appears to have increased in area in couple of slices. So the only positive factor in his blood work both the time was a positive UDS for THC. And after reviewing the research, last year in AHA, there was 2 cases presented where there is marijuana-induced, stress-induced Takotsubo cardiomyopathy. And I was not sure if anybody else has seen something like this. At this time, it is speculative that this is the reason why he's having chest pain related to the marijuana.
So positive THC, you said.
Positive THC on both the admissions.
Wow.
So, and there are some articles, if you Google and go to the AHA, there was a poster and they reviewed all the Takotsubo cardiomyopathies for the last, whatever, some X number of cases, and they found young people were at a higher risk when they're using marijuana because they're not able to sure whether it's linked to the marijuana or any adulteration in the marijuana.
Very interesting. I've not seen.
Yeah, so I thought this may be something for the group to discuss at some time.
Yeah, we'll have to ask Travis and Brent and some of the cardiac MR folks next time they're here. But yeah, thank you.
And I'll be happy to send the full cloud link to you.
Okay, great. Thank you.
Yeah, I'll send it to you, Dr. Jeff.
All right. Well,
thank you very much.
Yeah, thanks. All right, everybody. Well, thank you, and we will resume next week.
Okay, see you next.
Bye, everyone.
Bye.
Bye.